This is section 2.7, patient financial communication in the CRCR program. In this course, we're going to address the patient financial communications best practices through the concepts of financial counseling. Patient financial care concepts include negotiating account resolution, identifying and initiating financial assistance processes or charity, and pursuing time of service collections and achieving account resolution. Financial counseling. Financial counseling is done to help prevent patient to help the financial counseling is done to help the patient understand his or her health plan coverage and financial responsibility for his or her healthcare services. Components of financial counseling include informing the patient of the hospital's financial policies, explaining health plan benefits, providing cost estimates and or good faith estimates when applicable under state and federal regulations, discussing financial responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient so appropriate resolution of the healthcare financial obligation is achieved. Patient liabilities are comprised of two types of self-pay dollars. One type is pure self-pay, where the patient is uninsured and is responsible for the total cost of the healthcare service. The second type is the self-pay balance after insurance. These amounts are the cost the patient is responsible for, which is determined by employers and health plans and includes plan deductibles, coinsurance amounts, copayment amounts, and any non-covered services as identified by the health plan or employer. Patient Financial Communications Best Practices was developed by an HFMA task force of industry leaders to address patient communications regarding health plan coverage, financial counseling, financial responsibility for service, and unpaid balances. A complete copy of the best practices can be found in the Resources tab of our CRCR program. They also address the most appropriate ways to conduct financial interactions at every point in the patient-centric revenue cycle, from the moment emergency or non-emergency medical services are scheduled, or a patient arrives for a non-scheduled service for elective and non-elective procedures. Compliance guidance is included as well as an annual training requirement, technology assessments, and annual reporting to the C-suite on this topic. These best practices address the timing of the financial conversations in emergency department or ED and at time and service outside the ED and during the pre-service contact. Current as well as prior balances are included in the conversations. Upon request, the patient is allowed to use a patient advocate or family member to assist in conversations. Anticipating charges and determining the patient's financial responsibility. This includes clinical information. All available clinical information is used to anticipate charges for the patient's healthcare services. Patient responsibility estimates can be completed using pricing software tools if available, or they can be completed manually using average charges for specific procedures and/or case rates. Health insurance. For patients with verified health insurance coverage, staff uses anticipated charges and applies the health plan contract terms. These terms must be applied to identify the estimated approved charges. Contract requirements. Understanding exactly how each contracted health plan adjudicates the benefit package is vital to accurate calculations. For non-contracted health plans, there is no discounting provision and therefore no need for contractual allowance amount. Financial responsibility. Once the financial responsibility has been identified, a state and federal compliant estimate is provided when applicable. The financial counselor initiates a conversation with the patient to explain health plan benefits, the price determined using the benefit information, and also helps the patient identify an account balance resolution. During this conversation, prior unresolved balances may also be included in the resolution discussion. We discussed created estimates in the last section, so this should provide you with the ability to have a conversation on patient liability, including past due balances. Options are full payment, short-term payments, or potentially a bank loan program. If financial resolution cannot be obtained through any of these options provided, then financial assistance screening should be initiated through Medicaid and hospital financial assistance programs. Medicaid eligibility screening may occur through a variety of approaches, all designed to qualify patients for medical assistance. Typical approaches are presumptive eligibility, which is in the Medicaid expansion states, is included via established electronic processes. County or state workers maintain an office in the hospital and meet with patients may also be something that occurs in your facilities. An outsourcing firm may also meet with referred patients and help them complete the application process. Or internal staff within the patient access department screens the patient application based on current Medicaid guidelines and refers cases which qualify or are borderline eligible to local Medicaid offices for processing as well. Financial assistance is offered when the responsible party does not have the ability to pay and does not qualify for Medicaid assistance. This is often based on a sliding scale discount amount up to 100% discount based on the patient's financial status. Each provider determines the amount of discount or free care. However, the basis for the qualification is typically the federal poverty guidelines published annually by the federal government. Each provider must comply with the rules included in the Affordable Care Act. Financial assistance represents an account resolution option which must be managed within guidelines set by the provider. Communicating effectively with patients can be complicated by the negative implication of the use of the term charity. Presenting financial options and provider-based assistance opens a dialogue without the negative effect of the charity term. Patients who are either underinsured or uninsured are screened for potential financial assistance. The provider's financial assistance policy and application are presented to the patient. The financial counselor may assist the patient with the application. Information requested typically includes 4 categories of information: demographics, income, assets, and expenses. Time of service collections program. Part of the successful time of service collection program involves training staff how to request payment and conduct the conversation in a way that minimizes barriers to payment. Scripts are an effective staff tool to provide guidance on how to conduct the interview, ask for payment, and overcome payment obstacles. Begin the interview with a simple greeting to the patient. Make sure you provide your name and explain why you're meeting with the patient at this time. Respect the dignity of the patient and attempt to establish a rapport. Do not treat the patient as simply the next object to be processed through your office. Inquire if timing of your visit represents an acceptable time to talk about financial matters. Assume that the patient may not understand both how health insurance works and how hospital charges for service work as well. Be prepared to explain how you determined what the patient owes and be prepared to show the calculations. Once the patient understands how you arrived at the amount due, simply ask for the payment in full. When you receive the payment, process it according to your hospital's receiving rules and provide a detailed receipt to the patient. The last step in time of service collections is processing the payment. For any payment activity, there must be appropriate security measures and balancing procedures in place to safeguard the collections. This includes issuing receipts, posting the payment to the patient's account, completing balancing activities, and depositing the collected amount. A numbered receipt must be issued for each payment, and each numbered receipt must be tracked to ensure that no payments are lost. Ideally, payments should be posted directly to the patient's account and an electronic receipt issued. If electronic posting and receipting is not available, manual tracking of receipt numbers and copies of all receipts issued must be incorporated in payment processing requirements. All payments and receipts should be secured in a locked location to prevent accidental or deliberate theft of funds or credit card numbers. Processing time of service payments. Payments and cash drawer must be balanced at the end of each shift. To balance payments, the payments are totaled, the receipt amounts are totaled, and all receipt numbers are accounted for. The two totals should match. If they don't match, the differences should be documented and reported immediately. Key points. We've already talked about the components of financial education, including informing the patient of the hospital's financial policies, explaining health plan benefits, discussing financial responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient. We talked about the different categories of information that include demographic, income, assets, and expenses. And then we talked about the financial component of financial counseling in order to get to resolution. So, what is the purpose of financial counseling? Is it one, to address the appropriate way to conduct financial interactions? Two, is it to train staff on how to request payment and conduct conversations? Is it three, to educate the patient on his or her health plan coverage and financial responsibility for services? Or is it four, to help the patient understand exactly how a contracted health plan will resolve their benefit package? The answer is number three. Components of financial education include informing the patient of the hospital's financial policies, explaining health plan benefits, discussing financial responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient. This concludes our program of 2.7.